I'd like to welcome everybody to the House Health Committee. Will the clerk please take the roll?
Representatives Alexander, Boyd, Clements, Freeman, Gant, Hakeem, Hall, Helton, Hicks, Jernigan, Kumar, Leatherwood, Marsh, Mitchell, Ramsey, Sherrill, Smith, Vaughn, Whitson, Williams, Chairman Terry.
Here.
Mr. Chairman, you have a quorum.
All right, thank you. And do we have any personal orders of any of the members? Okay, seeing none, we have a pretty robust calendar. I do have a few announcements to make. Item number one, House Bill 578 has been rolled to the second calendar of 2022 without objection. Item number four, House Bill 1132 has been rolled till next week. Item number 19, let me make sure this is correct with Chairman Williams, 974 rolled to next week. Yes, rolled to next week. Okay, that brings us to our calendar today, and we're going to start off. We already disposed of item number 2 last night, so we will be on item number 3, House Bill 577. Chairman Reagan, you're recognized. You have a motion and a second.
Thank you, Mr. Chair and Committee. This bill has an amendment on it. Its amendment number is 6665.
You have a motion and a second on the amendment.
Thank you. And this amendment does delete the language and rewrite the bill. So it makes the bill. I'll explain the amendment, or you can put it on and I'll explain later. Your choice.
Okay, if there's no objection, let's go ahead and vote on the amendment. I get this on the bill in the proper form. Amendment 6665. All those in favor say aye. Opposed? Ayes have it. Okay, we are on the bill as amended. You are recognized.
Thank you, Mr. Chair and Committee. This bill, as it stands now, the amendment was put on there, brought to me by the Department of Education to help me get rid of the fiscal note that was on the original bill. If you look carefully, you'll notice that the fiscal note on the amendment is now not significant, so we'll go through. So let me briefly explain, as amended, what the bill does. The purpose of the bill is to ensure that the family life curriculum information meets state standards. That's Tennessee state standards. Additionally, the bill allows a parent of a student to request to review the information in that curriculum and opt a student out of any portion of the family life curriculum without penalty, which is very similar to a bill you heard on the floor today, but not the same as. This only applies to that family life curriculum. This bill does not change state requirements concerning contraceptive information, and it still requires emphasis that abstinence is the only method that removes all risk of sexually transmitted disease and pregnancy. The requirements in the bill are, first off, that information presented in that family life curriculum must be medically accurate, age appropriate, and in compliance with this part, which is also requiring that the LEA review it and ensure that it meets state standards. That is the bill as amended, explained, and I stand ready to answer questions.
Okay, any questions for the sponsor? Okay, seeing none, we will be voting on House Bill 577 as amended. All those in favor say aye. Opposed? Ayes have it. Bill goes on to government operations.
Thank you, Mr. Chair and Committee.
All right, thank you. And I am going to go out of order here. We have some folks that were here to testify and make sure that they get to testify today. And I've spoken with the sponsor on this as well. We're going to go out of order without objection to item number 26, House Bill 1027. Chairman Kumar, you are recognized.
Thank you, Mr. Chairman. In this day and age, we hear a lot about this.
Okay, you have a motion and a second.
We hear a lot about discrimination in certain realms of our society, but this bill is about caring and love of our young people. The House Bill 1027 serves to protect young children and minors from decisions and therapies that have lifelong consequences, and they are certainly at a too young an age to make those meaningful decisions. It is about hormonal treatment of prepubertal minors to block or reverse their normal human development to puberty. At ages 8 to 14, these children are not able or ready to make decisions about choosing their gender, even if they are assisted by caring adults, medical professionals, and counselors. It is just too early to start a journey in medical interventions and lifelong physical, emotional, and psychological consequences. As the bill states, Section 1, Part B, standard medical practice does not involve prescribing hormone treatment for gender dystrophic or gender incongruent pubertal minors, except as provided in the subsequent section. So it is not standard medical treatment, and we are basically taking that fact and codifying it into House Bill, through House Bill 1027.
Chairman, let me, let's get the, I think you're describing the amendment. Let's get the amendment
Okay.
properly before us. So it's 5771. So you do have a motion and a second on the amendment.
I apologize, I did describe the amendment, but that's what it basically does. It takes standard medical practice about avoiding very early age and prepubertal treatment with hormones in these young children, and we are putting it into code. Hormone therapy for other medically needed conditions will continue. And with that, Mr. Chairman, I'll be here to answer any questions.
Okay, do we have questions on the amendment? Representative Clemens, you're recognized.
Thank you, Mr. Chairman. I have a question for the sponsor. I've correct me if I'm wrong, but I've heard numerous times it's serving in the Health Committee over the years with the sponsor that we should not be codifying standard of care. Why is this instance different?
Chairman Kumar, you're recognized.
I think there are circumstances where it is necessary to protect children, and this is certainly a special circumstance.
Representative Clemens.
Thank you, Mr. Chairman, and thank you, sponsor. Standard of care is standard of care. If we don't want to codify it in one instance, why would we want to codify it in another? Just for some specific, maybe personal view or other. And it's been stated already that this is not being done because it's the accepted standard of care. So I fail to see the purpose for the bill. And I want to make sure, and I'm worried about us being consistent, where they're going to codify standard of care or not. So thank you, Mr. Chairman.
All right, Chairman Kumar.
Thank you, Mr. Chairman. Representative Clemens, the one point to note here is that there have been previous guidelines by various professional societies that are being progressively changed and transgressed. So there is a tendency towards going towards earlier and earlier age. And this is an effort to avoid that mission creep, so to speak, so that we don't continue down that path. And there, if you look at the 2017 guidelines, there has been definitely a change since that time.
Representative Clemens, you're recognized.
Thank you, Mr. Chairman. And Mr. Chairman, I just want to inquire, we are going to hear testimony today from a professional who actually practices in this area. Is that correct?
There is someone on the list to testify. We can either testify now on the amendment or get
Discretion of the chair. I just wanted to clarify.
Okay. Yes,
Thank you.
There will be. Okay. Any further questions on the amendment? Okay, seeing none, without objection, we're going to vote on Amendment 5771. All those in favor say aye.
Aye.
Opposed? Ayes have it. Okay, we are back on the bill as amended, and pursuant to the question that just got proposed, I'm going to go out of session. We have a couple of folks here that are wanting to testify. So without objection, we're going to go out of session. The first person would be Cassie Brady, Dr. Cassie Brady. And just for the record, who you're with, state your name, and happy to have you here.
Thank you. I'm Cassie Brady. I am with the Pediatric Endocrine Division at Vanderbilt Children's Hospital. So my name is Dr. Cassie Brady. I'm a board-certified pediatrician and pediatric endocrinologist at the Monroe Carroll Jr. Children's Hospital at Vanderbilt. I'm the co-director of our multidisciplinary team providing care for transgender youth. I'm speaking today on behalf of my team, the transgender patients that we serve, the other medical providers across the state seeing these patients, and the patients' families they see. The care of transgender youth is complex. A great deal of care is taken at every step of the process to ensure the safety and welfare of the children and families we serve. Doctors and mental health providers adhere to extensively researched professional guidelines set forth by national and international specialty organizations, including the Endocrine Society, the American Academy of Pediatrics, the World Professional Association of Transgender Health, the American Psychological Association, and other organizations. Providers across this state utilize these guidelines when initiating affirming medical care for transgender youth. There are safeguards at every step of the process that are above and beyond what is required for other pediatric conditions. Decisions to begin hormone therapy are always informed by the current best practice guidelines and include input from mental health providers, other expert physicians on our teams, as well as by the individual parent and their caregivers. Detailed informed consent is obtained from the patient and guardians prior to starting any medical care, such as the puberty blockers or affirming hormone therapy. These treatments we provide are life-saving. Transgender youth are an increased risk for suicide. Nearly half consider it, and a third actually attempt it. When receiving gender-affirming care, suicide risk declines, and these individuals live longer, healthier lives. House Bill 1027 focuses on hormone treatment of pre-pubertal minors diagnosed with gender dysphoria. Our guidelines already state that the use of blockers or gender-affirming hormones is not medical practice in children who are in Tanner stage 1 of pubertal development. Physiologically, blockers do not work unless a patient is in puberty. While House Bill 1027 does reflect the current standard of care, there are concerns about placing this in the code. Thank you for considering these issues and taking the time to hear from providers delivering care in this population.
All right, thank you for your testimony. Chairman Kumar, would you like to speak?
Thank you. Mr. Chairman, thank you, Dr. Brady, for being here. And I think you have confirmed what we are saying mutually. We agree that hormonal therapy in Tanner stage 1, which is very pre-puberty, is not current treatment, standard medical treatment. We agree on that.
We do.
Okay, good. So the only question is whether this matter should be put in code, and I think you heard our concerns that there has been a creep in from the 2017 guidelines where things are moving in an earlier direction, and these children are certainly too young to make those decisions, and that is the reason that we are considering this legislation. But we are not treading on your territory. We are not telling you what to do because that is what you're doing anyway, and I have respect for you professionally and the conditions that you're treating. Thank you for being here.
Thanks.
Thank you. You're recognized. Okay. Any further questions? Representative Clemens.
Thank you, Mr. Chairman. Doctor, do you have any response to what Dr. Kumar said about you not having any concerns about any of this?
You're recognized.
Well, I would like to comment on the fact that when we talk about age and how that's creeping back in using this hormone therapy, we don't base our hormone treatment or our pubertal blocking treatments on age. We base it on Tanner stage pubertal development, and that's based on physical exam and laboratory findings. And puberty can start as early as 8 in girls and as early as 9 in boys and be completely normal. These hormone treatments are used already in precocious or early puberty and are completely reversible, safe medications that have been used for many years. So I don't have concerns using them in this population or any other population I use them in. And I agree with the fact that you brought up earlier that maybe my standard care that I'm using shouldn't be put into code.
Any further questions?
No, thank you, Mr.
Okay.
Chairman. Thank you.
Representative Alexander?
If it's a standard of care that you're currently using, what problem do you have with it being put in code?
You're recognized.
No other standards of care that I use are put into code. I use standards of care for my diabetes patients and my Turner syndrome patients and all of the other endocrine patients I see. And I'm not sitting in front of a group testifying for those standards of care.
Thank you.
Any Representative Kumar? Chairman Kumar?
May I clarify two things for the fellow members? Tanner stages are various stages of pubertal development. Stage 1 being that puberty has really not started. The secondary characters of pubertal development have not occurred yet. And stage 5 being that they are fully developed in their secondary sex characters. After having done that, I don't think that we are taking the standard of care, borrowing it and putting it in code. I think it just happens that the opinions and feelings of the public officials that we are putting into code happen to fortunately coincide with the standard of care. If I may clarify that.
All right.
Thank you.
Thank you. Any response? No? All right. Any further questions? Chairman Williams.
So for us that aren't doctors, the question about Tanner 1, if you could tell me the different stages in which you provide therapy and what the typical age for those would be.
Sure.
You're recognized.
Thank you. Tanner 1 is no puberty whatsoever. And so that means that the brain is not signaling ovaries or testicles to secrete those pubertal hormones.
Right.
And so to get to Tanner 2, there's a specific laboratory value for the brain hormones, as well as the gonadal hormones, the testosterone and estrogen. And we have physical exam findings that key us in that Tanner 2 is developed. Average age of puberty is around 12. But like I said, normal puberty can begin at 8 for a little girl and for those born girl, and at 9 for those who are born boy. Anything before that is considered precocious or early. Late puberty is around 14, 15 usually for boy and girl.
All right. You're recognized.
Thank you. Thank you for that. I guess the next question for me is if I come in with my son or daughter, and my son or daughter is interested in this hormone therapy, what is the process for you as a physician determining whether or not you want to assist with this therapy? I guess what are the parameters that you're looking at as a clinician as it relates to how you will move forward with this person or not?
You're recognized.
As a physician, I'm guided by the mental health providers that these children are required to see. And once that mental health provider has made their assessment and written me a very formal assessment and letter, and parents have provided informed consent, the child is in Tanner stage 2 development, and I've met with them and agree, then we move forward. It can take several months.
You're recognized.
And so if the parent is not involved in the situation, I've had this discussion with a minor who's wanted to do this, but they do have a therapist who's willing to provide them a letter. Well, how does that situation work with you? Do you proceed with therapy?
No, I must have both parents, if they are involved, legally involved, then they have to have consent.
You recognize?
Thank you. And just to further clarify, all this bill would prevent, all this bill would do would codify a current practice that you have, that children 9 and under could not get this therapy, but children 10, 11, 12, 13, 14, 15, now with a permit they can drive, 16 and 17. Is that correct?
You recognize?
As far as age goes, it really depends on if they're in puberty. So if they're in puberty, they can get this therapy.
Thank you.
Representative Clemens?
Thank you, Mr. Chairman. And I just want to return back to something my colleague asked you about and you referenced was the mental health care that the children receive. Can you elaborate on what that mental health care, I know you don't provide it yourself, but can you elaborate on what that is before they ever get to you?
You recognize?
So the mental health care provider must have certification in either licensed clinical social work or psychology or psychiatry. Usually we do not use psychiatrists, but we will use psychologists and therapists that are licensed and experienced in gender affirming care. So it's not just anyone, and we have an extensive list of individuals we'll use and interact with. It requires specific sessions with them, and they use the DSM-5, which is a diagnostic textbook for diagnoses. And we don't necessarily like to say that if you're transgender, you have a diagnosis, but we still are reverting to using the DSM-5 for diagnosing gender dysphoria in order to make it to get hormone therapy. And there should not be any other kind of complicating psychological concerns at the time. Granted, these individuals can be depressed and anxious and other things, but that should not be clouding the picture in any way. And that's when the therapist works very, very closely. They meet with the therapist far more than they meet with me. Weekly, sometimes bi-weekly, sometimes every other week, depending on what the therapist sees fit.
And
You recognize?
Thank you, Mr. Chairman. And you mentioned some pretty alarming suicidal numbers. Can you repeat what those were? I missed the exact numbers.
Yes. So nearly half of children, oh, sorry.
No, you're recognized. Go ahead.
Nearly half of children who are transgender will consider the suicide, and a third will actually attempt it, which this is much higher than the general adolescent population.
Double. Is that all right? Is that a fair assessment?
I don't know off the top of my head, but it is quite high compared to the general adolescent population.
Okay. Thank you. Thank you, Mr. Chairman.
I think, Chairman Vaughn, you recognize?
Thank you, Doctor, and thank you for being here. If this piece of legislation passes out of our committee today, will this preclude you from administering treatment to any patients that you believe need treatment? Or is it a one of those, hey, I don't like to see my standard of care written in code? I'm trying to find out if this would diminish your practice, or is it just guardrails that you really don't want to have for you? That's my question. And
Okay, thank you. As of right now, it would not affect my practice, but science is always changing. Medicine is always changing. And so I can't say 10 years down the road, 3 years down the road, what might be different in the research we've done.
thank you very much.
Thank you. Follow up on that question. So what if this bill did go through, someone that is not following the standard of care, and I'm not saying that there's anybody that's out there that's not, but assume that somebody did not follow the standard of care, this would put something in place to have an action on them. Is that your understanding?
That's my understanding.
Yeah. Okay. Thank you. Any further questions? Mitchell? Okay. Representative Mitchell.
Yeah, thank you, Mr. Chair. And you said something a moment ago. I just want to make certain I heard this correctly. You said there is no other standard of care for any illness, procedure, sickness that you know of that is codified in the code. Is that correct?
You recognize?
For my specialty.
Okay, for your spec. So do you know of anything any other standards of care that are codified in law?
You recognize?
No.
Okay, so that just tells me we're picking something out and discriminating against one area, whether it's medicine or no matter what you're doing. If we're picking out one area, that's discriminatory. All right, thank you.
Chairman Kumar, would you like to respond?
Thank you, Mr. Chairman. I would like to assure for one thing that with this bill, if it becomes legislation, it will not interfere with your practice. One. Two, also concerns about increased suicidal ideations and attempts and so on. The care that children at this age, pubertal children will receive is going to continue, and this will not in any way at all interfere with that also. As far as searching our code and searching the standards of care, it's not going to be easy to find out. And I would say that there is not any standard that is not in the code or anything like that. I'm sure one can be found. And it's not our intent. Our intent is certainly not that. Our intent is that we tread into this territory very carefully because discrimination comes to mind. Nobody likes to be blamed of that. We don't want to be in that role, certainly. And we are very, very aware that these are children that need love and care. They should not in any way feel that they're being singled out. That's not our intent. And as I said, we tread very carefully and very slowly into this direction. Yet it seems that there is a need to protect these children who are young. And the other blessing, of course, is that they are, of course, under the care of good professionals like yourself and the mental health counselors and so on. For that reason, I feel comfortable that this should be put in code, again, to protect the children who are so young. Thank you, Mr. Chairman.
All right. Thank you. Representative Freeman, you're recognized.
Thank you, Chairman. Can you just go back for 1 second and repeat the process of the parent involvement and what those steps look like? And can you just describe what that looks like?
Mhm. Absolutely. So anyone who is under the age,
You're
sorry.
recognized.
Anyone who's under the age of 18 who's a minor, at least in our clinic, and with our guidelines say should have consent, informed consent from both parents. And for our clinic in particular, I can't speak to every other clinic in the state because I'm not in their clinics, but we have to have both parents there. And so that means if parents are divorced and one disagrees and one agrees, then that child cannot have the hormone or hormone blocking therapy. We do work with our legal department, though, when we have questions regarding a parent who might not have been involved but may still have some kind of legal documentation. That steps far above the physicians and our social workers and goes to more experienced folks.
You're recognized.
Thank you. And thank you for that. And you're unaware, but the members that are up here are not. Earlier today, we had a piece of legislation that allowed for parents to opt out of education curriculum that would have taught the kids about LGBTQ and sexuality. And the statement was made at that point that we need to let the parents choose. And it sounds like we've got an opportunity right here to really practice what we preach and let's let the parents choose. So thank you.
Thank you. Chairman Williams, you're recognized.
Thank you. As a follow-up, do the parents choose now? I'm sorry, do these reflectors, they're created to blind people so we can hide in plain sight. Do the parents choose now? The parents are involved in the process. Do they not?
Oh, the parents?
Yes.
No, you.
Yeah.
Sorry,
They
it took
are-
me 2 years to get used to that.
They are highly involved, the
Okay.
parents. Mhm.
Yeah, I think, to my good friend from Nashville's comments, the parents are involved in this process. We,
Mhm.
at least by your recollection, that they are for your clinic. I think one of the interesting parts about what we find, whether it's as it relates to this kind of care, or every year I've had people come to my office and say, I want to change this in my practice act. I want to be able to do this instead of the other thing. We codify what physicians and physical therapists and optometrists and ophthalmologists can do all the time. This bill, as amended, would not prevent any parent from doing that. It would simply, much like a practice act, set a guideline or what an expectation is. And then if it changes and children decide to do that the age goes up or comes down, then we can have a discussion about it. I think it's very important that for us, and particularly all of us, regardless of what side of the aisle on, that the parents are involved. I think but not everyone's practice may be like yours. Not every physician in their community may require the parent to be involved. I don't know. By your own testimony a minute ago and communicating with the process, you clarified that at your clinic. And what that infers to me, that there is a possibility that it might not occur at every clinic. And I appreciate that you're doing this very responsible and with accountability for both you and your patients. But I guess when you said that, I wondered, is there a possibility, and you don't have to answer this, but is there a possibility in this state that people aren't acting like you? And so that's a reason why I think this is a good idea. And maybe an exception.
You're going to.
Sure. I can comment on the practice in Memphis, Chattanooga, Knoxville, Johnson City, here, that everyone is practicing the standards of care and similar to our clinic as well. And that's where most of the major children's hospitals are in this state.
Thank you. Chairman Kumar?
Thank you, Mr. Chairman. Once again, thank you. It's a good discussion. I think this is important. It will serve to reassure these children who may be too young or their parents that there is no agenda here. Guidelines, in my experience in medicine, are exactly what they are. They are guidelines. And I think you would agree that variations from guideline are quite common in the practice of medicine and surgery. So for that reason, I think it's a reasonable precaution to take. Once again, the intent is to protect these young children, and with our concern for that. Thank you. Thank you, Mr. Chairman.
Thank you. Chairman Jernigan, you're recognized.
Thank you. Here I am. One quick question. If this was not law and someone did deviate from their standard of care, that's open up to malpractice. Is that not right?
You're recognized.
And harm came from deviating from the standard of care.
Well, I would think so, but I will say that if you deviate from this, because this is saying that you would start pubertal blocking in a Tanner stage 1 individual, if you were to do that, it wouldn't work. And so I don't know why someone would do that.
Okay, thank you.
Okay. All right, thank you. Any further questions for the witness, for Dr. Brady? Okay, Chairman Kumar?
Give me, as a last thing, it comes to mind, I'm thinking, do we ever put guidelines in code? We control the practice of medicine in various ways, and we recently, a few years ago, did that with opioid prescriptions. We interfered heavily in that. Thank you, Mr. Chairman.
All right, thank you. Thank you for coming today. I do want to tell the committee and those in the audience, those listening, you and I had an extensive conversation on this, and everything from what happens before puberty, during puberty, all the way through surgery, the detransition, the psychological background, all that. And you're very well versed, and you educated our committee, and it was a pleasure talking to you at that time. Pleasure having you in front of the committee today. And again, thank you for coming.
Thank you.
All righty, we have, while we're out of session, looks like we have one more person that would like to speak, and that is an Allie Chapman, if they are here. Any of those, and just make sure you turn on it'd probably be better if you come in the middle there and turn on make sure the microphone's on. Just say your name and if you're with somebody, who you're with.
Am I on?
Yep, we can hear you. Thank you.
Okay.
And try to keep the comments to 3 minutes and we'll, there's some questions potentially.
I'll be good.
Thank you. I know you
Yeah.
would. Thank you.
My name is Allie Chapman. I'm here as a concerned Tennessee citizen, constituent of Representative Manis, and a mother of a transgender son. To speak in opposition of HB 1027 or any amended version that may prevent, remove, or interrupt life-saving health care. Just like every other transgender person, there are some here. My son is not mistaken, he is not confused, and he is not deviant. It is so challenging for me to sit and hear the debate and the discussion around human beings in this way, but I don't think there's a recognition that by having these debates and breaking down people into pubertal stages and codes, that there's a missing element, which is this human. I can say that a CDC actually reports that LGBTQ youth are 4 times more likely to attempt suicide than the general population. And that the Trevor Project actually has found that one of these youth attempts suicide every 45 seconds. So we're already tallying quite a few here in this moment. There are already a host of other bills and laws that restrict our children in classrooms and clubs, sports, textbooks, school restroom use, and access to mental health care. But at its core, this bill reaches into the home, the most sacred space for parents and caregivers, families and children. And this intrusion adds yet another barrier where one isn't welcome, needed, or helpful. My son, Fox Schweiger, is now a young adult and recently testified in opposition to this bill's companion, SB 126. He highlighted the many barriers that our family faced to access, coordinate, and maintain the continuity of life-saving care that he needed. Our family relied on trusted advisors, therapists, medical and mental health providers, and we were all guided by the best practices that are shown to protect and benefit children, specifically transgender children. Unfortunately, we also found that culturally competent nurses, doctors, dentists, specialists, therapists, psychologists, and other types of healthcare providers that are skilled to care for transgendered kids are rarities. We quickly learned that even the best health insurance offers limited to no coverage for some of the necessary services and treatments, straining our budget by many thousands of dollars. The cost alone of the specialized health care is an insurmountable barrier for many families. We measured and considered every benefit and every consequence. There were no flippant decisions. We did everything possible to support him because it was the right and most loving thing we could do, and because we wanted our child to survive and not die at the most basic level. I do want to say that the phrase social issues keeps coming up when referring to Tennessee's LGBTQ-related legislation. How every child exists in all of their identities, including the color of their skin, their ethnicity, their origins, religions, and abilities, is not a social issue, but the way that we choose to talk about, treat, and legislate against them is a social issue. Transgender children aren't broken, but the constant debate, their dissection, and the persistent harmful language will break them. It is not hyperbole that we will lose them. They will die. I do not understand how these very real tragedies are dismissed. As a mother looking at the big picture, this bill looks like yet another step towards systematically removing, harming, or killing transgender children just like mine. This bill and its debate perpetuates stigma and further dehumanizes transgender people. I urge you to reconsider HB 1027 and any other bill that aims to oppress and erase an entire population of people. Thank you.
All right. Thank you. Chairman Kumar?
Thank you, Mr. Chairman. Ms. Chapman, thank you for being here. It takes a lot of courage, one, to sit in front of this atmosphere as well as to talk about things that is very personal and very dear to you. We have great respect for you, and sincerely, anything that we are doing here today is meant to protect children from getting treatment at too early a stage of life, and also the fact that it is inconsistent. It is completely consistent with the current practice of medicine. So in that sense, except for putting in our books, we are not in any way interfering. There is It will not interfere with the current treatment of transgender children. It will not at all interfere in any way about their mental health, suicidal tendencies. And I think those things are very, very important to us. We represent citizens, we represent you, and we represent the values that our constituents transmit to us. And we do that in a most meaningful way. I think these are leaders, these are thoughtful people. All of these people have been elected and they've been trusted with doing the right thing. And what we do is also open to you, and you can see that, and that's why you're here today. Once again, thank you for coming. I assure you that we are not in any way interfering in the treatment of these children. We are actually, I think Dr. Brady has confirmed that we are not interfering with treatment, and we care about these children. There is no animus here at all. I want to assure you, because we have children of our own, and children are children, like yours and ours. Thank you, Mr. Chairman.
Thank you. Representative Freeman?
Thank you, Mr. Chairman. And I would be remiss if I didn't comment and thank everyone in the audience wearing purple in support of this cause today. I just want to comment on one thing that that you brought up, and that's the stigmatization that we're putting on this. And you know, we have situations today where best practice is hormone therapy for kids and for prepubescent kids. That we don't talk about. That's not a concern here. The reason we're talking about it is because of the false belief that the members of the LGBTQ community are somehow not normal or not right. And ma'am, I apologize that you've had to come down here to try and to defend the rights of your son. We've got to stop doing this. And again, I just want to thank you and thank everyone again in the audience wearing purple in support of this cause today.
Thank you. Okay. Chairman Kumar, do you like to respond or?
No, Mr. Chairman,
Okay.
I respect the representative from Nashville's opinion, and I want to assure him that our intent is essentially to protect these children. And I think, thank you for your remarks.
All right, thank you. Any further questions? Okay, seeing none, thank you for your testimony. Okay, without objection, we will go back into session. Okay, we are back on House Bill 1027 as amended. Chairman Whitson, you're recognized.
Thank you, Mr. Chairman. And I had a discussion yesterday with a constituent, a mother of a young lady that's 10 years old, and it was a very moving discussion, and the challenges they face is with their young daughter. And Chairman Kumar, I understand, sir, that this does not change any of the treatment that's currently providing these children, but just want to make sure that we don't have any more amendments placed on this when it makes it to the floor. Do you agree with that, sir?
Chairman Kumar.
You have my word.
Thank you, Chairman.
Representative Mitchell, you're recognized.
Yeah, thank you, Mr. Chairman. I oppose this legislation because it creates new standards of legislative interference with physicians and parents as they deal with some of the most complex and sensitive matters concerning our youth. It is undisputed that the number of minors who struggle with these medical conditions is extremely small, but they too deserve the guiding hand of their parents and the counseling of medical specialists in making the best decision for their medical and individual needs. This legislation puts the state as the definitive oracle of medical care, overriding parents, patients, and healthcare experts. While in some instances the state must act to protect life, the state should not presume to jump in the middle of every medical, human, and ethical issue. This would be and is a vast government overreach. And I wish I could say I was that eloquent to have wrote those words, but it was the governor of Arkansas, Asa Hutchinson, as he vetoed similar legislation last week in Arkansas. So I'm just asking this committee, listen to those words. And let's just think, ladies and gentlemen of this committee, first we went to the bathrooms, then we went to sporting events. Now we're going to people's health care. You know, I'm hearing separate but equal. You know, we're not doing anything different, but it's different. It's the only thing we're codifying. So it's separate than all the other standards of care. So we're creating separate but equal. I mean, what's next? Where are we going next, ladies and gentlemen? You know, I'm just worried. It sounds too familiar. I don't like repeating history, especially when it's bad history. But we're going down that path, and I know we're a better state than that. Thank you.
Chairman Kumar.
Thank you, Mr. Chairman. I have a great respect for the gentleman to my left, and I think he's to my left ideologically too. And yet, it's an honor to work with Representative Mitchell. Once again, we cannot really draw a line in our society between medicine, politics, and ethics. These domains constantly crisscross and overrun. As I mentioned, we interfered in the practice of medicine by limiting the opioid prescriptions. We were treading into medicine, certainly. And ethics medical ethics are very much a part of the law, and we are lawmakers. So there is not a hard line between these domains as we work in the public sphere, and they constantly cross over. And I think this is one of those situations. Thank you, Mr. Chairman.
All right. Thank you. Speaker Marsh, you recognize. We have objection. Would you move to withdraw? Okay, motion has been withdrawn. Next person on the list to ask question, Representative Clemens, you recognize.
Thank you, Mr. Chairman, and I'll be brief as possible here because the debate itself is what is harmful here. We've established that through expert testimony here today that even treating prepubertal minors would be ineffective in some cases. It would be reversible in some cases. The standard of care is being codified. It's what the standard of care is, but we all know science changes, as the doctor said. And only argument that I've heard in favor of this bill is that this won't change anything. But the reality is science changes. Now, you know, that's just a fact. And the doctor who testified said that this is the standard of care in all these facilities that specialize in this across the state of Tennessee. So then we have to back up and ask ourselves, why are we doing this? And again, it's the debate that is harmful, and that's why I want to be as short as possible. The fact that we're even talking about something that's not even necessary. We addressed the standard of care with opioids because doctors were handing out opioids like candy. This is completely distinguishable. Nobody is breaking the law. There's not been one single instance. In fact, we've established this as the standard of care. And that's dangerous. And I would just emphasize to my colleague from Davidson County's point, we keep having these debates. And I know books are next. You know, if any of you, if your children, if you knew your child or your grandchild had a 50% chance of thinking about suicide, or if your child or grandchild had a 3rd% chance of trying it, you would not be having this debate or bringing this legislation. Because this very discussion and putting this in the headlines repeatedly is what's leading to this. It's the stigmatization. It's the discrimination. Please,
Out of order.
please, I beg of you, let's stop. This is unnecessary, and let's end the debate. Thank you, Mr. Chairman.
All right, thank you. All right. Previous question's been called. Without objection, we are voting on House Bill 1027 as amended. All those in favor say aye. Aye. Opposed?
No.
Ayes have it. Bill goes on to government operations. That brings us back to the start of our calendar. What, number 5? I need to find it. Okay, item number 5, House Bill 967 is, where's she? Where's she?
She's sitting in the crowd.
Where's she? Oh, there she is. Okay. Yeah, okay. Okay, without objection, we're going to take a 5-minute recess. What number is this that we're on? 967. Okay, we're good. All righty, we are, with objection, we are back in session. We are on item number 5, House Bill 967. Representative Carringer, you are recognized. You have a motion and second.
Thank you, Mr. Chairman. I bring to you House Bill 967. This bill authorizes certain healthcare professionals licensed in another state to practice telehealth while providing healthcare services on a volunteer basis through a free clinic. Under present law, a healthcare provider must be licensed to practice in this state in order to provide telehealth services. And I have Ms. Caroline DeBerry from Remote Area Medical here to speak, if you all would like to go out of
Okay.
session or.
Chairman Ramsey? Okay, without objection, we will go out of session. And for the record, tell us your name, who you're with, and try to keep your remarks under 3 minutes. You might have to push a button there to turn the mic on.
Am I on?
Speak again.
Am I?
Yeah. Yes. Oh.
Officer? Oh,
Is there
okay. I think, okay.
Yeah, there you go.
There we go.
Yeah, perfect.
All right, thank you. I'm Caroline DeBerry. I'm Chief External Affairs Officer for Remote Area Medical. And thank you so much, Chairman Terry, for allowing me to speak today. It is an honor to be here to speak in favor of Representative Carringer's House Bill 967, which would ensure the future of free telehealth for those who need it most. Remote Area Medical is an international nonprofit that provides dental, vision, and medical services for free and has been doing so for over 35 years. Typically, we do this with mobile, in-person clinics. But in response to the pandemic last year, we launched a free telehealth program. And thanks to Governor Lee's executive orders, we were able to do so. We worked with Commissioner Piercy's team to ensure that we were crafting the program in such a way that it allowed this telehealth program to continue. What made it so special is that the majority of our telehealth providers doing this on a volunteer basis have unencumbered licenses from out of state. This is the same spirit of volunteerism that the General Assembly endorsed and encouraged back in the 1990s with the Volunteer Healthcare Services Act. The Volunteer Healthcare Services Act permits out-of-state licensed providers in good with licenses in good standing, of course, to provide in-person care at free clinics and has, again, been doing this since the 1990s. And so Remote Area Medical has really benefited from this because it maximizes the amount of free services we can provide Tennesseans who need it most. So this bill would just continue that and make sure that this free telehealth service with out-of-state licensed providers can continue for years to come. So thank you so much. It's an honor to speak in favor of House Bill 967.
Thank you for your testimony. Do we have any questions? Representative King.
Thank you, Mr. Berry, for all the work that you and those around you contribute to our communities across the nation. What I wanted to ask you is that are there events or programs that we'll say specifically for veterans and so forth?
Wonderful question. Thank you so much for that. We welcome anybody at our clinics. We do not typically design our clinics for veterans specifically, but I can say that I have been working on different efforts to collaborate with, for example, Philips and others that intend to target veterans if we can. But that is something that is very important to us. At this point, though, we do not have events that are specifically for veterans only.
You're recognized.
The services you provide, are there I guess, in-state providers who would consider you in some way competition or a problem, so to speak, for them?
That's a wonderful question as well. Thank you, sir. So we actually, that's something that we will talk to people about both for our in-person and our telehealth clinics. And I would say I would hope not. These are patients that sadly are not going to be going to the doctor otherwise. For example, they're working 2 or 3 jobs and they don't have time during the week to take off to go see a doctor. Or maybe they don't have health insurance, or maybe the health insurance that they do have, the deductibles are too high. So at this point, everything that RAM does, including our telehealth program, is geared specifically to help those that need it most, have no other options.
All right. Thank you, Mr. Chairman.
Thank you. Any further questions? Representative Mitchell.
Yeah, I just wanted to say thank you. I've kept up with what your organization has done over the years, and I appreciate all you do throughout the world and especially in Tennessee. Thank you so much.
Thank you, sir.
Thank you. Seeing no further questions, thank you for your testimony. Appreciate you being here. Thank you. Without objection, we'll go back into session. Any questions for the representative? Representative Smith, you're recognized.
Thank you, Mr. Chairman. And Representative Carringer knows I'm going to ask this question just so that it'll be spoken into the record. Are the services that will be impacted and delivered by this bill reimbursed at all through insurance or for any sort of financial compensation?
You're recognized.
Thank you for that question, Representative Smith. Absolutely, there are no reimbursements, no charges. It's totally free clinic.
Thank you, Mr. Chairman.
All right, thank you. Any further questions? Okay. Seeing none, we're going to vote on House Bill 967. All those in favor say aye. Aye. Opposed? Ayes have it. Bill goes on to calendar and rules. All right, thank you. That brings us to item number 6, House Bill 345. Chairman Carr, you're recognized.
Thank you, Mr. Chairman. This is a bill to just continue on with the Elder Abuse Committee. We were supposed to have a report back to the legislature of January of 2021, and our COVID kept us from doing that. So that extends this committee to another year, and our report will be due to the committees on January, I believe it's the 15th of 2022.
All right. Any questions for the sponsor of the bill? Okay, seeing none, we are voting on House Bill 345. All those in favor say aye. Aye. Opposed? Ayes have it. Bill goes on to government operations.
Thank you, Mr. Chairman and committee.
Thank you. That brings us to item number 7, House Bill 1464. Representative Cochran, you're recognized. You have a motion and a second.
Thank you, Mr. Chairman. House Bill 1464, we've obviously talked about this in subcommittee some, but essentially this is ensuring that anyone with a cognitive disability is not discriminated against on the transplant list. So as long as their condition does not affect the viability of the organ that they are receiving, it would not affect their position on that list. And so I feel like a very pro-life piece of legislation, just again, making another statement that all lives are equal here in the state of Tennessee. I'll yield to any questions.
Okay. Any questions for the sponsor of the bill? Seeing none. Thank you. Good bill. We are voting on House Bill 1464. All those in favor say aye. Opposed? Ayes have it. Bill goes on to insurance.
Thank you, Chairman and committee.
All righty. I think we've got, I'm going to, for those other members that may be around here, we're going to hear this bill, and then I'm going to jump out of order after this bill. So we are on item number 8, House Bill 1080. Chairman Sexton, you're recognized. You have a motion and a second.
Thank you, Mr. Chairman, committee. I have an amendment 7013.
Okay, let's see. Motion and a second on 7013. Okay, you are properly recognized on that amendment.
Thank you. This amendment rewrites the bill, and it also incorporates all the changes that were made with the amendment that was put in on the health sub. the drafting code 6452. And it's relative to the establishment of the Board of Physician Assistants. It adds to the traditional language to cover the period of time between that the Board of Physician Assistants is legally established and when the board is appointed, and the operation that was put in the Senate. And it updates section 6319-108 to include the doctors of podiatry, osteopathy, and changes the effective date from January 1, 2022 to the effective upon becoming law. And all this bill does, and this amendment, is just creates a board for the PAs. Every other, I think the nurses, podiatrists, psychologists, chiropractors, they all have a board, and the PAs is the only one that does not. So this will be creating that board.
Okay, any questions on the amendment? Okay, questions on the amendment? We are voting to add Amendment 7013 to the bill. All those in favor say aye. Opposed? Ayes have it. We are back on the bill as amended. Do we have any questions for the sponsor of the bill as amended? Okay, seeing none, we are voting on House Bill 1080. All those in favor say aye. Opposed? Ayes have it. Bill goes on to government operations.
Thank you, Chairman, committee.
All righty, we're going to jump out of order here real quickly. We're going to go to item number 17, House Bill, without objection, House Bill 948. Chairman Boyd, you're recognized. You have a motion and a second.
Thank you, Mr. Chairman, and I do have an amendment.
Okay, what is that amendment number?
I'm showing drafting code 6740, Mr. Chairman.
So you have motion and second on amendment 6740. Go ahead and explain your amendment.
Thank you, Mr. Chairman. The amendment makes the bill. What this amendment and bill seeks to do, it is a much needed and well thought out reform to Tennessee's Certificate of Need program. It makes various changes, creates more regulatory flexibility. It eliminates some of the protectionist aspects of Certificate of Need. It reduces some of the Certificate of Need regulation of certain facilities and services, lowers the population threshold mark, which triggers Certificate of Need for certain categories like non-pediatric MRI services and pet services from the current 250,000 threshold down to the 175,000 threshold. But more importantly, it eliminates a lot of the red tape. It makes the process quicker, easier, cheaper, reduces paperwork, speeds up the process, and it requires the HSDA executive director to develop a plan to merge the Certificate of Need program with the healthcare licensor into a single agency. And no later than January the 1st of 2023, that report will be submitted to the General Assembly. Mr. Chairman, I can take any questions that anyone has, and I also have HSDA Director Logan Grant available to testify if needed.
Okay. Representative Alexander, do you have a question?
I noticed that on page 17, Mr. Boyd, you might not have it, but anyway, it talks about 175,000 population. And I'm wondering why we even have that in there and why we even need the 175. Why, that just eliminates almost everybody in Northeast Tennessee. We'd like to see this bill for everybody.
Chairman Boyd, you recognize?
Thank you, Mr. Chairman, and that's a great question, and this actually was well thought out, and I was about to answer it, but actually, Representative Robin Smith the other day had one of the best answers I've ever heard of that, and so I'm going to defer to her, Mr. Chairman, if you'll allow.
Representative Smith, you recognize?
Thank you, and I know that Chairman Boyd has worked on this, and I want to applaud a lot of people that have worked on this, especially our speaker, since 2015, and I guess the easiest answer is that for 9 months, we had stakeholder meetings for over a year, about 9 months to a year. And this was kind of part of the agreement, is to slowly edge into a phase into a type of a reform. And so this is something where the market will have time to adjust. And again, we were just talking about how that instead of lurches and fits and starts on something this sweeping, it'll give different populations an opportunity to change the market dynamics.
Representative Alexander.
I just kind of think it's very unfair to the other communities that are smaller, that are not getting the same opportunity, especially in the rural areas. We desperately need this amended to include them.
Thank you.
Thank you, Mr. Chairman. I don't disagree, and there was a lot of thought that went into this and a lot of collaboration, and this is the number that all of the stakeholders, when they came together, including a lot of the folks in the General Assembly, that's the number that we kind of ironed out. But I don't disagree with you. I think a lot of people would like to see it expand.
Thank you. Chairman Williams.
Thank you, Chairman. Chairman Boyd, before I ask you or comment on the bill, I just wondered if you could tell me what HSDA stands for. I'm just kidding. Chairman Boyd, I want to thank you for this bill. I do agree with Representative Smith. This has been a long time coming. I think CON is a integral part of how we did medicine corporately across the state. It did have a time and place for it, and I do think that these changes are really good. I'm going to support this bill. I do think, though, much like my good friend from God's country in the Upper East Tennessee, there's one component that I think that I would wish that we would change, in particular that would be important to my own community, and that is, and I have a bill to do this, but I've agreed not to run it because this is really important, and that is mental health services are a huge challenge for rural Tennessee. I carried one of the first telemedicine bills because there wasn't a lot of mental health and psychiatry services in rural Tennessee, and so we were able to do telemedicine that way. But in Tennessee, if someone presents in a hospital at Cookeville Regional Medical Center, sometimes they wait 4 to 5 days to be able to get in Representative Smith's district and Moccasin Bend to get the help that they need. I think if we limited it to distressed areas or rural designated areas, then it would exhort or encourage development in rural Tennessee in the same fashion or way that this certificate of need process facilitated large hospitals and large communities. But as I said, I'm going to support this bill, but I'd hope that going forward, we would consider ways in order to try to get mental health facilities and services in rural Tennessee. Thank you. Thank you, Chairman.
Thank you, Chairman Boyd.
Thank you, Mr. Chairman. And Chairman Williams, that is a good piece of legislation. We appreciate you parking that for us because I do think this bill will take care of that. Thank you.
Thank you. Chairman Ramsey, you're recognized.
Yes, and let me just quickly make a comment about the population limit. What we see, and I have a government hospital in my district. My district is about 145,000 people. And I could not vote for this if it didn't have the population limit on it. What happens, my hospital, a lot of these rural hospitals have unreimbursed care of levels that city hospitals don't even face. So my hospital collects about 26 to 30 cents on a dollar as far as charges. And so what happens when other competing businesses come in, they don't have to give unreimbursed treatment. The hospitals do by federal law. So we couldn't operate if somebody came in and competed for that small portion of the people that have reimbursed care. So that's why the population is in there. With the population limit, I'll be able to vote for the bill.
Thank you for comments. Representative Alexander, do you have a comment?
I understand that hospitals, have to treat everyone, but I don't think there's a treatment center in my area that's not a hospital that's not treating everyone. I've asked. And so it's really hard for them to see always only the big cities getting this stuff.
Thank you. Chairman Boyd.
Thank you, Mr. Chairman. And I do want to clarify, members, lots of times here in the General Assembly, we will pass legislation with population thresholds, and it's based on like the 2010 census, and it stays there pretty much permanently. This is actually a number that is fixed, and as we do new censuses in the future, if you grow into this, you will be included in it. So this is not based on the 2010 census. So if you're the county that you're talking about after the 2020 census, if you move into that, and you probably won't, I'm not saying that you will, but you will eventually be included in this. So that 175 number will take into consideration future censuses.
Thank you. Leader Gant.
Thank you, Mr. Chairman. I have a county in my district, and I just want to get clarity on, excuse me, on this. If they had a former hospital and that hospital closed, this would apply. This legislation would apply.
Chairman Boyd.
Thank you, Mr. Chairman. Yes, and the hospital that we discussed offline, it would be included in this. This legislation would take care of that.
You're recognized.
And one follow-up question. If I understand that if the counties are designated as a economically distressed county, this also applies, correct?
Chairman Boyd.
Thank you, Mr. Chairman. Yes, if a county is economically distressed, they are exempt from the certificate of need regulation.
Leader Gant.
Is there a continuation period after a county comes off of a distressed list that they carry over so many months? Do we know the question to that? Answer to that?
Thank you, Mr. Chairman. So if a hospital went in while they were distressed and then they got taken off the distressed list, the hospital could continue to exist. But if they came off of the distressed list and said, we were on it last year, we'd like to do it, that rule would no longer apply. You would have to be distressed at the time that you applied.
You're
Thank you,
recognized.
thank you, Mr. Chairman.
Right. Thank you. Chairman Williams. You're recognized.
Thank you, Chairman Terry. I just recognized a bearded man who just walked into the back of the room. He's half the person he used to be in size, and that is the former State Representative Tim Wergo. I'd like to welcome back to the House Health Committee. Good to see you, Tim Wergo.
Thank you. Out of order. Welcome back. Representative Smith, you're recognized.
Thank you, Mr. Chairman. And one of the things I think that I do want to applaud the way this bill has been kind of crafted in this iteration. And I hope everyone hears this. Dr. Ramsey made a point about concern about the payer mix and how that some hospitals will only accept TennCare and some hospitals will only accept commercial care. And by taking the approach where a certificate of need and licensure is married together, there will be an enforcement mechanism in a way to examine payer mix and making sure that people can't cherry pick. And that way the market will be stabilized for not just the very lucrative, profitable markets, but also the rural markets. So I do want to applaud all that have worked on this bill. Thank you, Mr. Chairman.
All right. Thank you. We're on the amendment. Any further questions? Okay. Questions have been called on the amendment. We are voting on Amendment 6740. All those in favor say aye. Aye. Opposed? Ayes have it. We are back on the bill as amended. Any further questions for the sponsor? Okay, seeing none, we're going to vote on House Bill 948 as amended. All those in favor say aye. Aye. Opposed? Ayes have it. Bill goes on to calendar and rules. Oh, it says goes to calendar and rules. Okay. Okay. That bill, last bill 948, needs to go to finance. So without objection to finance. Okay. We have still a robust calendar, but we only have 5 minutes left here for our time frame. They have to clean the room, and so all these bills that we did not get to today will be heard next week. So, without objection, all remaining bills will be rolled to last calendar. Seeing no further business before us today, we are adjourned.